Hello everyone. So let's start our next topic, gastrointestinal pathology. Like we discussed, that pathology is the most important part of USMLE step 1. So we'll start with oral cavity disorders. The first is silolithiasis. Silolithiasis is a stone in the duct of the salivary gland. What is the cause? Dehydration and infection. Most common cause, dehydration and infection. Stone in the duct of salivary gland. So this is not uncommon. Patient will present with pain and swelling of the affected gland. Most commonly submandibular gland, I saw a few times. Treatment is conservative. You can give them Silogogs, warm compression for the pain. You can give them NSAID and then massage to dislodge the stone. Single stone formation is common in submandibular gland, resulting in Wharton duct. Not uncommon. So you can see it on ultrasound. And this is how it will present. This is the stone. Silolithiasis. Again, another image. Submandibular gland, sublingual. Siloadenitis, infection of the major salivary gland caused by Staph aureus. Another cause is if there is obstruction by stone in the salivary gland, that can also cause siloadenitis. It is an autoimmune disease. Treatment is antibiotic, depending on the organism. So if it is MSSA sensitive, oxacillin, nafcillin, if it is mRNA resistant, then you can use Bactrim. You have other choices too. What are the oral manifestation of HIV? Candidiasis is most common. Aphthous ulcer can be viral or immunological. Hairy leukoplakia, glossitis due to Epstein-Barr virus. Kaposi sarcoma involve hard pellet caused by HHV8. Human herpes virus 8. And we'll discuss them in detail later. Next is aphthous ulcer. It is also called canker sore. It's not uncommon, it's very common. Canker sores. So when you look at these lesions, patient will present with painful lesion, and it consists of, it can be, let me change the pen, it can be round and it can be oval. Round or oval ulcer, and you can see that it is covered by yellowish exudate. Sometimes people have recurrent aphthous ulcer, and it's commonly associated with celiac disease. Celiac disease, there is another syndrome, Behcet syndrome. Sometimes HIV, like we discussed. SLE can also cause recurrent aphthous ulcer, also called canker sore, associated with celiac disease, Behcet syndrome, HIV, and SLE. What are the non-infectious lesions of oral cavity? Erythema multiforme. Whenever you see erythema multiforme, think about drugs, number 1. And second most common cause is infection. Number 1 is drug. It's a hypersensitivity reaction, most commonly caused by drugs. And in drugs, the most common drugs are antibiotic. Common in the hospital setting too. Stevens-Johnson syndrome is similar to erythema multiforme when it involves oral cavity. Third, aphthous ulcer, we just discussed. Third is Behcet syndrome. It's a small vessel vasculitis associated with HLA-B51, HLA-B27. It's a triad of recurrent aphthous ulcer, uveitis, and genital ulcer. This question is common in exam. So they will give you, patient will give you a history of recurrent aphthous ulcer, and they will ask you about the association. So commonly they will ask you more about uveitis. Patient will complain of blurring of eyes or uveitis finding. Or they can ask you about this striate too. Recurrent upper ulcer, uveitis, genital ulcer. What is your diagnosis? The diagnosis will be Bachelor syndrome. Treatment, NSAID. You can try steroid too. Prednisone. Next is pigmentation abnormalities. Peutz-Jeghers syndrome, increased melanin pigmentation, commonly happen on lips. We will discuss in detail later today. Addison disease, increased ACTH level, which stimulate melanin synthesis, can also cause pigmentation abnormalities of the mouth. Lead poisoning, black lines on the gingival margin. More chronic. Tooth discoloration, this is commonly in dental fluorosis. And it can also happen in newborn babies when the pregnant patient use tetracycline during pregnancy. Macroglossia, enlarged tongue, can cause in myxedema, is very common. Down syndrome, very common. Hypothyroidism associated with macroglossia too. Macroglossia, acromegaly, and then amyloidosis. Next is glossitis. What is the cause of glossitis? Iron and vitamin B12 and folate deficiency. Pellagra can also cause glossitis. Pellagra is a combination of 4 Ds: diarrhea, dermatitis, dementia, death. Next is, how will you differentiate between leukoplakia and erythroplakia? So leukoplakia is white patch. Erythroplakia is red patch on the tongue, commonly patched on tongue. Leukoplakia has 30% risk of cancer, and erythroplakia has 60% risk of cancer. So what exactly it is? Squamous hyperplasia of the epidermis, which progress to squamous dysplasia. Most commonly found lower lip, vermilion border of lower lip. Leukoplakia we are discussing about. Squamous hyperplasia of epidermis progress to squamous dysplasia, most commonly on the lower lip. This is leukoplakia, white patch. This is red patch. This is erythroplakia, increased risk of cancer, 60%. Increased risk of cancer in this situation is 30%. So which one is more dangerous? Erythroplakia. Benign tumors of the oral cavity, squamous papilloma, most common tumor, squamous papilloma. It has fibrovascular pore. So there will be vessel inside the tumor. High risk of bleeding because of the vessel. Ameloblastoma, located in the mandible. Enamel epithelium origin or from dentris cyst. Soap bubble appearance and translucency in mandible. It's not very common. Ameloblastoma, located in mandible. So the clue they can give you in the test will be location of mandible and soap bubble appearance. So this is a benign tumor of the oral cavity. It's more common in old age. I actually saw a few days ago. More common in old age, female. So this is the upper part of this is the palate. Squamous papilloma. Next is salivary gland disorder. So thing to remember is tumor which are arising from major salivary gland, like big gland, like parotid gland, they're mostly benign. And you will see them in the hospital or in outpatient setting more commonly. And the tumor which are arising from minor salivary gland, they are more malignant. Which gland is most commonly involved? Parotid gland. Usually present with painless mass. They will not have any pain. But let's say if you have a patient who is presenting with facial palsy, facial paralysis, severe pain, think about malignant possibility. Though parotitis can cause pain, but it will not involve the nerve. But let's say if the patient has parotid gland involvement, facial paralysis, or they have numbness, tingling of the facial region. If it is unilateral, then think about malignant possibility of malignancy. Now, what are the different types of salivary gland tumor? Number one is pleomorphic adenoma, benign tumor of the parotid gland, painless. You will, on the exam, you will find a mobile mass at the angle of the jaw. Histopathology, you have to remember, epithelial cells mixed with myxomatous or cartilaginous stroma. So I think having cartilaginous stroma is easy to remember. It's not very common. This is one of the tumor which has cartilaginous stroma. Treatment is surgery. It can undergo malignant transformation. Pleomorphic adenoma. It can undergo malignant transformation. This is how it looked like. Parotid gland. Pleomorphic adenoma. Histology. Next is Warthin tumor, papillary cyst adenoma lymphomatosum. That's the other name for Warthin tumor. But in the exam, they'll give you this option in the multiple choice. This is again a benign tumor of the parotid gland, common in smoker. Smoker is a clue. So in this tumor of the parotid gland, there will be no cartilaginous component. There will be only salivary tissue found in lymph node. Cystic gland-like structure entrapped in benign lymph node, lymphoid tissue. Let's look at the image. So this is the image. Next is mucoepidermoid carcinoma, malignant tumor of salivary gland, especially parotid. Histopathology, mucoepidermoid. So epidermis can be squamous, commonly squamous epidermis. So it has the mucinous component and squamous component. So if you look at this image, so this is the squamous component and this is the mucinous component. This is mucinous and this is squamous. In between, pink is squamous. Mucinous and squamous component. Mucoepidermoid carcinoma. This is a tumor of parotid gland. Next is esophageal disorder. You can easily get at least 2 to 3 questions from esophageal disorder. Esophageal disorder, embryology, pathology, pathological embryology, they are all very important. So just for quick clues, how to answer questions based on their complaint. If patient is presenting with heartburn, epigastric discomfort, think about GERD. Common things are more common. Dysphagia to solid food, old age, weight loss, think about cancer. Stricture, if it is stricture or web, think patient will be young with history of chronic GERD. Dysphagia to both solid and liquid food, motility disorder. Think about eclasia. Upper esophageal oropharyngeal skeletal dysphagia due to myasthenia gravis, dermatomyositis, or stroke. Lower esophageal dysphagia, think about systemic sclerosis and CREST syndrome, but that's not the only clue. We'll discuss more about it.